All right, Pharm Week 1 Respiratory Medications. Antihistamines for colds, stuff. Okay. For allergic rhinitis, this is a fancy way of saying seasonal allergies. So we have antihistamines, which are taken orally, glucocorticoids, which are taken intranasally, cromolyn sodium, which is taken intranasally, and sympathomimetics, which are taken orally and intranasally. So histamine comes as either a H1 or H2 receptor, and it is an endogenous compound found in specialized cells, is used for both allergic reactions and gastric acid secretion, found in lots of skin tissues. So for H1, this is going to be responsible for our typical allergic reaction response. So vasodilation, which leads to tissue swelling, increased capillary permeability, again, leads to tissue swelling, bronchoconstriction in the lungs, and CNS effects such as, I don't know, actually, memory difficulties and sleep-wake cycle disruption. There we go. H2 receptors are just about making gastric acid secretion, which was covered in week 3. H1 antagonists, these are not going to block H2 receptors. They're only going to block H1 receptors, hence H1 antagonists. Some also bind to cholinergic muscarinic receptors, creating an anticholinergic effect, which is why we see here this kind of dry-looking tongue, which is dry mouth, also known as xerostomia. So our pharmacotherapeutics, we're going to have a decrease in local flushing, itching, and pain, and potentially some sedation, though that's more so with Benadryl, such as our first generation, rather than like loratadine, which is a second generation H1 antagonist. So we're going to use this for mild allergy, motion sickness, such as promethazine and diphenhydramate, insomnia, which we should not take very often for that, and common cold to decrease rhinorrhea or runny nose. Rhinorrhea, like diarrhea, but of the nose. There should be one for diarrhea of the mouth, via anticholinergic effects. Because with the anticholinergic effects, we're talking about a decrease in fluid released from the body in general. The adverse effects are going to be sedation, so you take Benadryl, you start getting sedated, start falling asleep, dizzy, fatigue, coordination problems, confusion. Those are all pretty general cognitive effects of taking Benadryl, especially a lot of them. Constipation can also be a potential problem, decreased appetite, dry mouth, blurry vision, urinary retention. A number of these are going to be due to anticholinergic effects as well. So high-risk patients are going to be those who might have drug interactions, those who are also taking CNS depressants like alcohol. We want to take caution in using this with young children and older adults since they have an increased susceptibility to CNS effects. And we will not be giving these to people who are breastfeeding or to newborn infants. Women who are breastfeeding, I don't think they're going to be, well, no, actually, there might be dudes now who are breastfeeding. I take that back. Oral antihistamines do not reduce nasal congestion. They reduce rhinorrhea. Rhinorrhea and rhinitis, or nasal congestion, are two very different things. Rhinitis is the swelling of the nasal cavity. Rhinorrhea is going to be the increase in secretions. With oral antihistamines for like seasonal allergies, your typical over-the-counter stuff, take them prophylactically prior to symptom development. They work a whole lot better that way. Adverse effects are mild, and we want to monitor and teach about anticholinergic effects like dry mouth, etc. Intranasal glucocorticoids are our first choice and most effective treatment for seasonal allergies. And this is going to be fluticasone. This is what we're going to see in Flonase. Again, mild adverse effects, may have some drying of the nasal mucosa or a sore throat. Maybe, every now and then, very rarely, have systemic effects. So adrenal suppression, slowing of linear pediatric growth. If you take them a lot growing up, maybe. But overall, very safe. No, don't do that. Intranasal cromolyn sodium is extremely safe, but is just kind of meh when it comes to effectiveness. This, unlike the other one where H1 receptors will block the receptors from interacting with histamine, this instead suppresses release of histamine from the mast cells, which is where histamine is kept. Again, as with most of these, best used for prophylaxis rather than after the symptoms have begun, and response may take 1 to 2 weeks to develop. For oral and intranasal sympathomimetics, these are going to reduce nasal congestion. They don't do anything for rhinorrhea. So H1N1, not H1N1, H1 receptor antagonists are going to be good for rhinorrhea. They're not good for rhinitis. I think I'm saying that right? I need to check, make sure. Okay, so decrease rhinorrhea, mild allergy. Some of these are a little confusing and exactly what they're referring to, but so reduce nasal congestion. They do not reduce rhinorrhea, sneezing, or itching. So really, they're just about opening up your nares and your nasal passages to help breathing through your nose easier. And they do that by activating alpha-1 adrenergic receptors in nasal blood vessels. And when we activate alpha-1 receptors, what we're actually doing is causing vasoconstriction. And so when we cause vasoconstriction, we are reducing how much permeability there is in those blood vessels and how much is causing tissue to swell within the nasal areas. So the medications for this are going to be pseudoephedrine, ephedrine, and oxymetazoline. And I believe on yours it actually says, stupid thing, both intranasal and oral compared to just my intranasal. Both of these can cause rebound nasal congestion, both Afrin and Sudafed. We can also have some CNS stimulation in the way of restlessness, anxiety, and insomnia, and then hypertension, tachycardia, and stroke due to vasoconstriction. Case study. Drugs for cough. Antitussives. These are going to suppress cough. So we have our opioid antitussives, which is going to be codeine, and our non-opioid antitussives, which is going to be dextromethorphan. So both of these, even the non-opioid version, are going to have the potential for abuse. And the high doses are going to lead to potential of euphoria and physical dependence. And then they can also work together with opioids to create an even stronger synergistic effect. So actually a lot of people, when I used to work at a youth rehabilitation center, when the kids would break out of the facility and run away, the first place they would go would be the Fred Meyers so that they can pick up some cough syrup that had dextromethorphan, chug the entire thing, and they would feel this euphoric effect. And that's why a lot of times now we have a restriction on who can buy cough medication at the local stores. Over-the-counter cold medications oftentimes have a combination of these medications, like, for example, Dayquil, NyQuil. Generally, we like to... These are okay for adults if they're healthy adults. People who have heart conditions, like maybe someone who's susceptible to PVCs or skipped beats, palpitations, are going to have problems with the antitussives. That happens a lot. So sometimes it's better to just go ahead and take individual medications, which is what we teach in general for geriatric and pediatric patients. So for the pediatric patients, there's no proof or efficacy or safety of these medications. There's even some proof of harm. So avoid in children who are younger than 2 years old. Only use the products that are labeled for pediatric use. Consult a healthcare provider. And use the measuring device provided with the product, because some people think, oh, a tablespoon's a tablespoon. No, it's not. No. Nursing techniques or teachings for geriatrics. Consider drug interactions. Um, Always ask what other medications they're taking, and it's our job to compare them. Talk to a pharmacist or look it up on Lexicon to do a little drug comparison thing. In general, the best advice is to use single agent over-the-counter drugs instead of these combination medications, except on a personal preference basis, knowing that you can manage it. COPD. Okay, I don't, whatever. Inhalation drug therapy. So virtually every COPD patient is going to be taking medications to try to maintain good flow through their airways. So we're going to want to have, we want to minimize the systemic effects that occur and have rapid relief in the case of times when we have an exacerbation. So a lot of patients are going to be on metered dose inhalers. So this could be albuterol, which is a SABA or a short-acting beta agonist, or salmeterol, which is a long-acting beta agonist, LABA. A lot of patients will also be on dry powder inhalers, which is what this doohickey right here is. You click it, you breathe in, it's kind of a dry powder, hence the name. And sometimes they're used for steroids or long-acting beta agonists. We also have nebulizers, which is what this kid's on, though it's kind of a special one since it plugs into this Lego set. That's really fancy. And then respimats are this newer format or medium through which we can supply inhalation therapy. And that's what this guy here is. Normally for like a short-acting beta agonist, you would see one that comes down here and out with an elbow. This is just straight. I guess actually it'd be going to this side. This is the part that your mouth goes on. And a respimat is different in that it's a soft mist inhaler, and it allows for more of the medication to get down to the lungs rather than kind of getting plastered out throughout the oropharynx and the throat. So one thing to keep in mind when it comes to talking about metered dose inhalers, always, always, always use a chamber, because the evidence has shown that you get way more of the medication down into your lungs using a chamber compared to just simply putting the inhaler up to your mouth. So when managing COPD, we're going to want to measure lung function using spirometer or pulmonary function tests. And then we're going to classify based off of that how severe the COPD is. Main treatment goals is to decrease symptoms so that they can improve exercise tolerance, which will help a lot towards the long-term health of their COPD diagnosis, and prevent progression of COPD and manage the exacerbations. So we're going to be using bronchodilators, anti-inflammatory agents, and phosphodiesterase type 4 inhibitors, which you won't see that as much from what I saw. So these are beta-2 agonists. Short-acting beta agonists will be albuterol. Long-acting beta agonists will be salmeterol. Albuterol is more the rescue med. This is the everyday long-term use. And then the anti-inflammatory agents would be like glucocorticoids, or for prednisone if it's going to be a injected or oral medication for an exacerbation. You may also see fluticasone for a long-term maintenance as an inhaled format. And then roflumilast is going to be our phosphodiesterase type 4 inhibitor, and we'll get into that in a bit. So SABAs are inhaled either alone or with an anticholinergic, such as Atrovent. Oh, this is for exacerbations. Okay, so yeah, we would start with our SABA. We would have our systemic glucocorticoids taken either by oral or by IV, antibiotics if they have an infection, and then supplemental O2. So bronchodilators are for... Let's see here, I don't like this. Nope, this whole thing. So bronchodilators are for symptomatic relief only, except for like long-acting bronchodilators. Okay. Sometimes you can have a bronchodilator and a glucocorticoid. A lot of, for example, dry powder format inhalers can have a combination of a LABA and a glucocorticoid. For example, Severant or Ceravent or Salmeterol. This is for long-term control. This is not to be taken as needed. This is a everyday on the spot, on the time, on the dot maintenance. All right, already went over that. So activation of beta-2 receptors in the smooth muscle of the lung leads to bronchodilation, making it easier to breathe. There will also be some minor increase in histamine release and an increase in ciliary motility, which will help towards getting stuff out of the lungs if there's any gunk built up in there. Again, this is long-term control in stable COPD on a fixed schedule, not as needed. For the inhaled version of salmeterol, systemic effects include tachycardia, angina, and tremor. For the oral version, with excessive doses, we have angina, tachydysrhythmias, and tremors. All right, theophylline. Theophylline is an interesting medication. This is similar to others in that it relaxes bronchosmooth muscle, leading to bronchodilation, helping us to breathe better. But it's got this really narrow therapeutic index. So there's a very high risk of leading to a toxic level in the blood, which means we have to be checking theophylline levels on a regular basis. And this can be given more as either PO or IV. So PO will be used for maintenance therapy of chronic stable asthma and is not any longer recommended for COPD. I have seen some patients still who are taking theophylline as a COPD patient or treatment, so maybe some hospitals are not quite up to date. I don't know. As for adverse effects, toxicity is plasma level dependent. So the more you have, the more worse it gets. At higher levels, we have nausea, vomiting, diarrhea, insomnia, restlessness, dysrhythmia, and convulsions. And if there is death, it will be resulting from cardiorespiratory collapse. So a person experiences an MI because they're not getting enough blood flow to the heart through being in tachycardia or a dysrhythmia, go into cardiovascular collapse. So if we take this with caffeine, we're going to increase the effects, leading to a potential of being in a toxic level. Tobacco and marijuana will decrease the levels, and then fluoroquinolones, antibiotics, will increase the levels. Okay, so for an anticholinergic bronchodilator, we have ipratropium bromide, which is Atrovent. This is commonly paired with albuterol in the way of a medication called a duoneb, which can either be given as an inhaler, I think as an inhaler, I think I've seen that a few times, but definitely as a nebulized medication in the emergency setting. This blocks muscarinic cholinergic receptors in the bronchi, so we are limiting how much acetylcholine is able to basically tell the bronchi to constrict, because acetylcholine is part of our parasympathetic nervous system, and the parasympathetic nervous system activation leads to bronchoconstriction, whereas sympathetic activation through norepinephrine and epinephrine is going to cause vasodilation. So blocking the cholinergic effects will cause bronchodilation. It's very fast-acting. They can be given, oh, there we go, MDI. Fast-acting, nebulized, and MDI. It's indicated for COPD and used for asthma off-label. It's used on a regular basis for many different kinds of respiratory complaints or emergencies. The systemic effects are rare because there's poor absorption from the lungs, so luckily it kind of just sticks in there pretty good. Dry mouth and pharyngeal irritation are really the only things that we might have from this. And I think that's more when we take it as an MDI. No, I mean, all right, they're going to be going in the mouth either way. I think nebulized is a little bit less because there's more moisture associated with it. Anti-inflammatory medications are going to be taken by some patients as a daily long-term control, such as glucocorticoids, fluticasone, budesonide. These are going to be a really good, powerful medication to maintain the airway. A lot of asthma patients I know, for example, use or see their glucocorticoid as the best medication they have. So it decreases the inflammatory mediators, decreases infiltration and inflammatory cell activity, which together, both of those are going to lead to a decrease in airway edema. What? They're going to lead to a decrease in airway edema. I don't know about airway edema caused by beta-2 agonists. And they can be taken as an inhalation, IV, or oral routes. So the overall, back on this. So dosing is on a fixed schedule, again, not PRN. And the inhaled versions are very effective and they're safer than the systemic versions. But they are not going to be used to abort an exacerbation. Even the systemic ones are not going to be used for like trying to quickly overcome a systemic or an acute exacerbation. Realistically, they're going to take about an hour, maybe 2 hours, to really get going. At which point, or until then, we're more using bronchodilators to try to really get things kept open. But the long-term fix, more often than not, is glucocorticoids. So the oral use will be used, or IV, depending on how severe it is, will be used for acute exacerbations of COPD, and only when the symptoms are not controlled with other safer medications. And that treatment should only be as brief as possible. And what they mean by that is they'll actually be sent home with this medication as well, like prednisone, prednisolone, and kept on that for a matter of days or maybe a week or two to make sure that they don't have a soon recurrence of the exacerbation. When taken acutely or inhaled, there really aren't any adverse effects, but they can be severe when taken long-term as a PO medication, not as an inhaled medication. And so they're going to be the typical ones that we might experience with glucocorticoids like adrenal suppression, osteoporosis, hyperglycemia, cataracts, glaucoma, peptic ulcer disease, and maybe diabetes. Moving on now to phosphodiesterase type 4 inhibitors, or roflumilast. This is going to increase the enzyme cyclic adenosine monophosphate, which is also known as CAMP or CAMP. And hang on. So if memory serves, CAMP is like a modulator of inflammation. So increasing it is going to result in a decrease in inflammation, cough, and excessive mucus production. The adverse effects are going to be diarrhea, reduced appetite, weight loss, nausea, headache, back pain, insomnia, depression. So in an acute exacerbation of asthma, which I think someone's doing this as their project, this is going to require immediate attention every time. The goal is to relieve airway obstruction, hypoxia, hypoxemia, and normalize lung function as soon as possible. So most of the time we're going to start them on oxygen. As soon as we start them on oxygen, we're also going to start them on nebulized high-dose albuterol and nebulized Atrovent. And then once that's started to kind of try to open up those airways, and if they don't really show any improvement or only minor improvement, or perhaps they only show improvement while they're having the nebulized medications, but then not when they're off the medications, then we're going to absolutely start a systemic glucocorticoid.